Good morning. A warm welcome to all of you. Let us start today's first scientific session. To chair the session, we have with us Dr. Venkatagiri KM, Dr. Harsuru, Dr. Abraham Cherian, Dr. Sukhminder Jit Babja, Dr. Manjunath Prabhu. I welcome all the chairpersons. Today's first talk is by Dr. Jayaprakash Muleli. Over to Dr. Jayaprakash Muleli.
It's my privilege to speak to you on a topic which I'm sure you're all very familiar with, research methodology. But it's always good to take a step back and review the process or mental process that guides you through this whole research-oriented activities every now and then to get fresh bearing and clear directions for the future. So I will start by telling you a story about a guy called Kepler. You must have heard this name, Johannes Kepler. He was a contemporary of Galileo. He had a hunch. And it is not even a hunch, he actually worked a little more on it. You see, populations living near the coast of sea coast always were fascinated by the tides going up and down. And they used to wonder what is causing this rising and lowering of the tide. Somebody, this is before Christ, had a hunch that the moon had something to do with it. How he figured it out, nobody knows. But he recorded it. So we know even in BC, people knew, thus suspected that moon was responsible for the tide. But what Kepler did was he measured the time delay of moon rising each consecutive day and found it was 41 minutes. Similarly, he noticed that the rising of the tide from day to day was delayed by 41 minutes. So there is a first evidence of some kind of a correlation which gave strength to the age-old hunch that moon had nothing to do with this rising and falling of water. However, Galileo was not impressed with this because he actually said this sort of a connections emerged from lunatic minds. But he had a reason for fighting against Kepler because Galileo had a theory that Earth rotated on its own axis. And he needed physical evidence to show people that Earth did rotate. And this rising and falling of water, or what he called the sloshing of the water, is a clear evidence that Earth was rotating. So he was not willing to part with that bit of hunch he himself had. It took many years of Isaac Newton's genius and his theory of gravity to show that actually, indeed, there is a connection between the rising of the tide and the moon. Now you see the story has got these three aspects. Number one, there is this aspect of a fact that the tides go up and down every day. Nobody can deny that. But we need an explanation. Why is the fact so? That's where the theory comes in. And scientific knowledge is primarily based on theories, which explains why facts are so. And the journey we took was several hundred years before Newton could explain this whole phenomenon. So in our process of dealing with research, we have facts, we have pandemics, we have mortality, and we have hunches. But how do we go about creating a theory as to what is going on? So research is not merely finding facts or correlation or association. Research goes deeper than that. It had to fit and create a theory. Facts don't change, theories do. We become better and better at understanding nature, understanding diseases. But you should remember that we all come with a frame of mind which has lots of information. And this information, when faced with a new fact, it has to fit in with the already available information. In fact, the list prepared by Bradford Hill on causality as a very little known statement about causality being explained. And this particular issue, like biological plausibility and coherence of evidence, look at the connection between the new knowledge or facts and how the theory explains these facts. If you can't create a plausible explanation, nor fit in with a known theory, then we have to ask this question: do we need a new theory? Anyway, I said it as a preamble because we are stepping into some understanding of methods available for us. You're all familiar with, I won't trouble you with it, but let us take the queen of all study design. And that is a laboratory experiment with, say, genetically identical mice. So what do the laboratory people do? They keep all conditions stringent and then divide this almost identical mice into two groups. And one is, say, exposed to tobacco smoke. The other group, no. And what they do is, after some time, sacrifice a mice and look for neoplasia. And let us say they find more cancer among tobacco-exposed mice. They conclude that all other being equal, all other things being equal, the difference must be because of tobacco smoke. You can do it in a lab. But human studies require a little more, preparation. There are different people. So what we do is we conduct what is called a randomized clinical trial, or to be more exact, a randomized double-blind or triple-blind clinical trial which is controlled with a placebo. That tries to mimic, create a laboratory atmosphere among people. The point is this magic of randomization creates a beautiful balance between the two groups that we create. So there is no question of conformity. It avoids selection bias. And also the masking avoids information bias. So having done this carefully, you have one group is exposed to a drug, other group is not. They get a placebo. You look at the outcome in terms of mortality. The question is, does the drug work? We, as observers, prepare our mind. Saying what? Listen, I need to be convinced that the drug works. So I'll make sure I'm not siding group A or group B. And that is the frame of mind that is encouraged in a clinical trial. And we call it a clinical equipoise. In other words, the probability the drug will be shown as a winner is about 50-50. Having done all these things with surgical accuracy, then you do the trial. But you still are skeptical, and your null hypothesis, there's not going to be any difference. And this null hypothesis is valid because the randomization creates two identical groups. And from there, you find the difference between the mortality. And when you look at the mortality, your first reaction is, this must be purely by chance. So your statistical test that you do is simply to ask the question, listen, I find a 4% difference between the two groups. Is it real or is it purely by chance? And statistical tests don't take any sides. They simply tell you a number. What is the probability the difference of this magnitude could have happened by chance alone? And if it's less than 5%, most of us agree that's too small a chance. And so we go with the line, the drug must be working. Now you see, this is the way we set it up. This is the way we analyze it. And in fact, in a clinical trial, there's no need for much confounder control because they're reasonably large. The randomization takes care of it. So we are in a great shape. I mentioned this because when you step in to observational study, it's full of landmines, okay? And there you have to be very careful. But before I describe the landmines there, let me make out one little difference in the way you appreciate clinical trial. P-values and the confidence interval. P-values gives you a probability of the difference occurring by chance, and less than 0.05, we say, yeah, the drug works. My contention is that is not a safe approach. P-values can fool you. Let me give an example of a very large study. Why is it large? It is not a regular clinical trial. It's a meta-analysis of a large number of trials. And the research question all these trials had was, does reducing salt intake reduce blood pressure in normotensive individuals? So all these trials dealt with normotensive people, and the trials, all of them, had a salt reduction of 5 grams at least. That is, the control group took 10.5 grams of salt every day, which is the normal practice. The intervention group took 5 grams or less. And the sample size worked out to, because meta-analysis, almost 100,000. And then came the results. The difference in systolic blood pressure was statistically significant. P less than 0.05. those who had lower salt intake had lower systolic blood pressure. Along with that was given the difference and the 95% confidence interval. The difference between the two groups in systolic blood pressure at the end of the study was 2 millimeters, and the 95% confidence interval ranged from 1 millimeter to 3 millimeters. Now you see, in this situation, I am going to conclude the other way around. I'm going to conclude a reduction by 5 grams of sodium chloride in your diet in normotensive individual makes no significant difference in systolic blood pressure. What about the p-value? That is the problem with p-value. P-value is blind to the magnitude of difference. They just say, what is the probability this much could have occurred by chance alone? And when the sample size increases, even ridiculously small differences become statistically significant. Important lesson. Now, when you go into the observational studies, you have got a new problem: confounding. Confounding is the biggest bugbear, and I don't have to explain to you what confounding is. There is selection bias, there's information bias, but most important, confounding. And you struggle with these biases, which you elegantly took care of in clinical trials. And then you come out with some sort of a figure. Remember, in most observational studies, cohort or case control, we go by risk ratios. In clinical trials, we go mostly by risk or rate difference. Why is that? Because even small differences in clinical trial from a clinical treatment point of view is important. In observational studies, we too can go for both of them, but the problem is this confounding makes small difference to appear very much, very quickly. So very often, non-randomized trial yield very promising result. But the moment you randomize and do a study, the results disappear. So how do you guard against such eventualities? And again, this is the caution we need to practice. The only thing we can hope for is don't get carried away by small differences or small relative risk. A relative risk of 1.2 from an observational study is pretty close to 1, which shows no association. So as a general guide, I would suggest that make sure that you are chasing large association. Smoking and lung cancer, the relative risk is 15, which means smokers have a 15 times greater risk as compared to non-smokers for developing lung cancer. No confounding can create that big relative risk. So anytime you are sitting with a relative risk which is more than 3, you are in great shape. Between 2 and 3, be cautious, be worried. At less than 2, you have to be immensely patient, because these confounding happen very, very easily when you do cohort and case control studies. Now, I know most of us have students who have to do a thesis, and then you get a statistically significant odds ratio, and the publication has to be made, or thesis has to be submitted. That's all fine. But I think you should be wise to realize this particular technology of creating odds ratios in general can be very, very dangerous. So I want to leave this message to you so that you have in your mind your own way of judging papers so that you don't get carried away by not so important associations. Thank you very much for your patient listening.
Thank you. Thank you very much, Dr. Jayaprakash. Next, we have Dr. Jiggy Devatya. Over to Dr. Jiggy Devatya, sir.
Good evening. I want to thank Dr. Manjeet and the team of ISAWEBCON Kerala for inviting me to speak to you today. Now, the topic I've been given is to talk on the 5 best publications in anesthesia in the last year. Now, I'm not in the habit of awarding trophies to publications, but I thought I would talk about the 5 most significant papers that I consider, but based on a certain theme. And I did not choose any papers outside of anesthesia. For example, I didn't choose papers related to intensive care, emergency medicine, or CPR. I chose 4 papers from 2019, the last year, which dealt with this theme, and 1 paper regarding COVID published this year, because we are living in the COVID era and it's important that we know what's happening in this area. And the theme that I chose was, are we causing serious complications by the administration of general anesthesia? Now, and this I think is extremely important, because if by giving general anesthesia, we are causing significant harm to patients, then we really need to look at what we are doing with our anesthetic techniques, right? So, the first paper which addresses this theme deals with the topic of neurodevelopmental outcomes in childhood. So does the administration of general anesthesia in infants result in worse neurodevelopmental outcomes in later childhood? And this, I think, is an extremely important question to answer. If by giving anesthesia in infants and neonates, if we are creating a situation whereby 3, 4, 5 years down the line, these children, because of the anesthetic, develop developmental delays, they become slow learners, they have disabilities, they are unable to socialize with other children, I think we are doing a disservice. And we really need this question to be answered, because there is data, lab data, animal data, to suggest that there is anesthesia-induced neurotoxicity. There is apoptosis of neurons with various anesthetics, and also there are human studies which support an association between surgery before the age of 4 years and later on a risk of behavioral problems and poor academic performance. So if anesthesia is doing this, then we need to know, right? Now, many studies have shown this association and many studies have not shown this association. And very often the association is shown after multiple exposures. Okay, so we need to know whether this is true or not. And lastly, none of these studies have actually done formal IQ testing. So this group of investigators did this extremely important study, and this was a randomized control trial. So you can actually have causation, you can know about causation. And what they had was, they looked at infants who were less than 60 weeks post-menstrual age, born at more than 26 weeks, so not prematures, who were undergoing inguinal hernia surgery. None of them had been exposed to GA before, and they had no other risk factors for neurological injury. And they were randomized into 2 groups, an awake regional anesthesia group versus a sevoflurane-based general anesthesia group. In the awake group, any form of GA was prohibited. So they were anesthetized awake and the surgery was conducted awake. In the sevoflurane-based GA group, nitrous oxide and opioids were not allowed, but regional anesthesia was allowed for post-op pain. And they did a formal assessment of intelligence quotient at 5 years of age using very standard psychometric tests. So they looked at 722 infants randomized to the awake regional anesthesia and half of them to the general anesthesia group. There were some protocol violations and dropouts. The median duration of anesthesia was just under 1 hour. It was 54 minutes. And what they found, that at 5 years of age, the IQ was 99 in the awake regional anesthesia group and 99 in the general anesthesia group. In other words, there was no difference in the IQ at 5 years, whether the child had received a regional anesthesia in infancy or general anesthesia, right? So this was a predominantly male population. So we can conclude that at less than 1 hour of GA in early infancy does not alter neurodevelopmental outcome at 5 years of age compared to awake regional anesthesia in male patients. Now, this is an extremely important result because it tells us that it is safe to give GA, maybe GA for less than 1 hour to infants, and there is no problem that is likely to happen 5 years down the line, right, or 4 years down the line. Of course, this does not address the possibility that longer duration of anesthesia or repeated anesthetics may have a problem, but at least it gives us some sort of reassurance that what we are doing is not completely off the mark. So I think this is a very, very important question that needed to be answered. And this study has given us a very reassuring answer that GA is safe, at least in this group of patients. The next question is, can the choice of anesthetic technique influence cancer recurrence and metastasis? Now, we are giving anesthesia to cancer patients on a daily basis. If somehow, without our thinking about it so far, without our knowing about it, and without our even this thought crossing our minds, if the anesthetic technique or the drugs somehow make the oncological outcomes worse, then that is not a good sign. Right? That's not a good thing for our specialty. And there is some data to suggest that anesthetics may have a role to play in cancer recurrence and metastasis. Now, in the perioperative period, before surgery, you might have a primary tumor and there might be micrometastasis. During surgery, the tumor is handled, there's shedding of tumor cells. At the same time, there's release of growth factors. There's suppression of anti-metastatic immunity. So some mild suppression of the immune mechanisms during surgery and immediately after surgery. And there's increase in pro-angiogenic factors. Now, and these can all promote cancer recurrence and metastasis, right? Now, if in the perioperative period, our anesthetics do something which promote the pro-tumor environment, then that can be bad for cancer recurrence and metastasis. And there is animal data, lab data, and some retrospective cohorts of human studies which suggest that, inhaled anesthetics and opioids, they impair cell-mediated immunity and they increase angiogenesis. And the opioids are supposed to be very bad. The stress response of surgery, right, also leads to impairment of immunity and increased angiogenesis. And all these factors can promote cancer recurrence. Regional anesthesia, on the other hand, none of these factors are involved, and it leads to preserved cell-mediated immunity, unchanged angiogenesis, and may promote control of minimal residual disease. In other words, GA may be bad and regional anesthesia may be good as far as cancer recurrence and metastasis is concerned. Now, this was a study which was a randomized controlled trial which was done in over 2,000 women undergoing potentially curative breast cancer surgery. And they were randomized to a regional anesthesia and analgesia group who received paravertebral blocks and propofol versus a GA group who received sevoflurane and opioid analgesia. And the primary outcome was recurrence of cancer or local recurrence or metastatic breast cancer. The median follow-up was 3 years, and they did some interim analysis, and on the second interim analysis, the trial was stopped for futility. And what did they find in this study? They found that there were exactly the same number of recurrences in the regional anesthesia group and the general anesthesia group. There was no difference at all, and there were no difference in the secondary endpoints of incisional breast pain. So now this is again a very reassuring outcome. It tells us that in breast cancer surgery, there is no difference whether you give GA or whether you give a paravertebral block or regional anesthesia. Okay, and we can use either technique. Now, this does not mean that we are completely off the hook. There is some suggestion that maybe if you did this strategy in operations which induced a greater stress response, which required more opioids, which were more major surgeries than breast surgery, which required more opioids in the perioperative period, then there might still be a difference. And we need to do these studies, and there are these studies ongoing. But at least in principle, for breast cancer surgery, we can say that, there is no difference between giving general anesthesia and a regional anesthesia technique. Now, when you're giving general anesthesia, is deep general anesthesia detrimental? Does it cause harm compared to, say, maintaining a lighter plane of anesthesia during surgery? And again, it would intrinsically, we would like to think that deep general anesthesia may be worse. And there are some studies which show that, you know, in observational studies, we've seen that if you give very deep anesthesia, you've got decreased post-op survival and more complications, but there has been no randomized controlled trial. So this was a trial taken by this Australian group, and of course it was a multi-center international trial, and they looked at reasonably high-risk patients. They were more than 60 years of age with significant comorbidity, having surgery with an expected duration of more than 2 hours and an anticipated hospital stay of more than 2 days. And they looked at 73 centers in 7 countries, and they randomly assigned patients to receive light general anesthesia, which meant a BIS, bispectral index target, of 50, or deep general anesthesia, which was in which general anesthesia was targeted to a BIS of 35. So light anesthesia, BIS target 50, or deep general anesthesia, BIS target 35. And all of them were given volatile anesthetics. They could get a regional anesthesia. They excluded patients who got nitrous oxide, a propofol infusion for maintenance, or a ketamine infusion rate more than 25 milligrams per hour. So no intravenous maintenance was allowed. It was largely a volatile anesthetic based technique, and with opioids or regional anesthesia. And the primary outcome was 1 year all-cause mortality. Okay, so they looked at 6,600 patients divided between the light GA group with a BIS 50 and a deep GA with a BIS of 35. The median BIS was maintained at 47 in the BIS 50 group, so slightly lower than target, and 38 in the 38.8 in the BIS 35 group, so slightly higher than the target. But the mortality was almost exactly the same. It was 6.5% in the light GA group and 7.2% in the deep anesthesia group. And this was absolutely not statistically significant. Interestingly, there was only 1 case of awareness in the light anesthesia group. So it was not a big problem if you gave light anesthesia, at least in this group of patients. And there was no difference in the quality of recovery, length of stay, or other secondary outcomes of cardiovascular and sepsis-related outcomes. And at 1 year, disability-free survival was similar in both groups. So you can see that here the BIS was around 40, over here close to 50, and here it was close to 38, 39, and here it was close to 48. So there's a difference in BIS. And despite having a higher, deeper anesthesia here, the BP was maintained. So the anesthetist made it a point to maintain the blood pressure, which was appropriate for the patient. And you can see there was not much difference in the blood pressures between the 2 groups. And predictably, with the light anesthesia group, they had a much lower MAC being given. And with the high deep anesthesia group, there was a much higher MAC being given to this group. But you can see there's absolutely no difference in outcome at 1 year. So in patients who are 60 years and older with significant comorbidity and with increased risk of complications, there was no evidence that light general anesthesia was superior to deep general anesthesia. So again, a very reassuring message that while we would like not to give very deep anesthesia, if sometimes we have to give deep anesthesia, it is probably not a major issue, right? So it defines a broad range of anesthetic depth. So we can go between 35 and 50, and you can titrate a volatile anesthetics using this. And the fact that there was only 1 incidence of awareness supports so that at least in this elderly patients, you can target a BIS of 50 quite safely without worrying about awareness. So again, another study which challenged a common concept that deep anesthesia is bad, and it actually reassures us again that deep anesthesia is not all that bad. Doesn't mean we should knock all our patients out completely and for a long time, but we should not worry too much in some patients we do have to give deep anesthesia for a period of time. Okay, so again, a very reassuring message which has come out of this study. Now, this study is about ventilation. Right now, we all talk about lung protective ventilation, and we know that a low tidal volume, which in anesthesia is about 6 to 7, 6 to 8 ml per kilo, with moderate levels of PEEP is better than high tidal ventilation with low PEEP. Now that seems to make perfect sense. But does a high level of, in the patients who are getting a low tidal volume, do you need high PEEP with alveolar recruitment maneuvers or low to moderate PEEP without recruitment maneuvers? Which strategy is better? And this study looked at it in obese patients. Right now, obese patients, remember, they have more risk of respiratory complications, they have more atelectasis, and they have impaired respiratory function during and after general anesthesia. During surgery, very often, we may need to use higher levels of PEEP and recruitment maneuvers to prevent atelectasis. And many anesthetists use this sort of strategy. What we don't know is whether this may improve oxygenation during surgery, but whether it prevents the incidence of post-operative pulmonary complications is not known. So this study was called the PROBEASE trial. It was conducted to test whether intraoperative ventilation using a high level of PEEP with recruitment maneuvers reduces post-op pulmonary complications compared with a strategy which used a lower level of PEEP without recruitment maneuvers, right? So this is a question which this study asked. So they looked at almost 2,000 patients. There were more women than men, and they were all adults with a body mass index more than or equal to 35. So definitely obese patients undergoing non-cardiac, non-neurosurgery under general anesthesia. And many of them underwent abdominal surgery, including laparoscopic surgery. They were reasonably young patients, 49 years, international multi-center trial at 77 sites. 1,976 patients were analyzed out of the 2,000 plus randomized. So half of them got high level of PEEP with recruitment maneuvers, and the PEEP was 12 centimeters. Okay, so PEEP was set at 12 centimeters, and the other got a low level of PEEP, 4 centimeters water, without recruitment maneuvers. So a PEEP of 12, and all patients got a tidal volume of 7 ml per kilo. So low tidal volume plus high PEEP of 12 with recruitment maneuvers, and low tidal volume with low PEEP of 4 without recruitment maneuvers. And the primary outcome was a composite of all pulmonary complications on the 5th postoperative day. And what they found that there was absolutely no difference again. So post-op pulmonary complications occurred in 21% of patients who received high PEEP and recruitment maneuvers, and in 24% of patients who required low PEEP without recruitment maneuvers. Difference of about 2% between the two groups. And amongst the secondary outcomes, again, most of them were not significant, but there were fewer patients with hypoxia, intraoperative hypoxia in the high PEEP group, which is expected. At the same time, there were more patients with hypotension in the high PEEP group, again, which is expected. So what did they conclude? That an intraoperative mechanical ventilation strategy with higher PEEP and alveolar recruitment maneuvers did not reduce postoperative pulmonary complications in obese patients. Okay, so now we don't know exactly how to interpret this sort of thing. 12 PEEP may have been too much. Also, PEEP was not individualized. Right? You give 12 PEEP to everyone, some may respond well, some may respond badly. You give 4 PEEP to everyone, some may respond well, some may not respond well. So maybe there is no individualization of PEEP which happened in these patients. But again, it seems to tell us that, our usual ventilation strategies are not all that bad, and we are not doing so badly. So again, a very reassuring message coming out of this study that even if you're not doing fancy things, if you're afraid of giving high PEEP and you're afraid of giving recruitment maneuvers, maybe it's not so dangerous, and maybe our convention. But remember, low tidal volume is a must. A little bit of PEEP is a must. Now, whether you give very high PEEP of 12 with recruitment maneuvers or a PEEP of 4 without recruitment maneuvers is equivalent, but it's still low tidal volume ventilation which is going on. And this seems to work pretty well for most patients, including obese patients who are at high risk of pulmonary complications. Okay, so I finished with 4 studies which dealt with the theme of post-operative complications, especially long-term complications. And we found that general anesthesia is not very bad for neurodevelopment if given to infants. We found that general anesthesia is not bad when given for breast cancer surgery. It does not promote cancer recurrence and metastasis. We saw that deep general anesthesia is not necessarily bad compared to light general anesthesia, and we found that standard low tidal volume ventilation with low to moderate PEEP is as good as low tidal ventilation with high PEEP and recruitment. So again, all these studies seem to support that we are not doing too badly with what we've been doing. Okay, now lastly, I'll deal with aerosols during this coronavirus pandemic. Now, we all know that, or we all think that intubation and bag mask ventilation are high aerosol generating procedures, and that's why we take full airborne precautions during these procedures. Now, there was this very, very, very provocative paper which came out just a month ago, maybe, in the journal Anesthesia, and these investigators, they measured the amount of aerosols, the particles that were produced during a volitional cough, and you can see that cough produces, a cough by the patient produces a significant amount of aerosols, a big peak over here, a number of small particles less than 2 microns, right? When they looked at intubation, they found almost no aerosol generation. Now, this is a bit of a surprise because we all associate intubation with being a very high aerosol generating procedure. But here they could find no aerosols with bag mask ventilation, laryngoscopy intubation, and cough inflation. And during extubation, in fact, there was a little more particle generation, and a cough during extubation produced even more particles. So according to this study, intubation doesn't seem to be a very dangerous procedure as far as aerosol production is concerned, but extubation is, and coughing by the patient at any stage is a bad thing, right? So one way you can look at this study is, well, you can be reassured that during intubation, you're not at very high risk. But if your patient is coughing, and a patient would cough at you anytime, right? You could cough in the pre-op checkup, you could cough in the OPD, someone would cough at you in the hospital while you are walking up and down the stairs, they have significant amount of aerosols. So these authors said that, we don't have to abandon taking precautions in the OT, but we should take more precautions outside the OT, where coughing of patients can actually produce these aerosols. So they said that tracheal intubation is associated with a very low aerosol generation, and extubation is associated with less aerosol compared to a volitional cough. Now, again, this study was in a very, very clean OT under some fantastic conditions. I don't know how these results will apply to some of our theaters. But it's also, soon after that, there was another study in anesthesia. And this study actually is more supports our conventional thinking, right? So this was performed, airway management, including intubation and extubation, were performed in a standard operating room. Okay, and they looked at aerosols in 3 procedures. And here they found that during intubation, bag mask ventilation produced a big spike in the amount of particles, including small particles. Tube insertion, a smaller spike, not such a big spike, but less than bag mask ventilation. This was a flow rate of about 6 to 8 liters, 6 to 10 liters. Cough inflation, a similar small spike. At extubation, mask ventilation prior to extubation produced a small spike. Throat pack removal produced a very small spike, and patient coughing produced a big spike, right? So in this study, bag mask ventilation, intubation, extubation, and patient coughing were associated with significant amount of aerosol of particle generation. And if you see this, these spikes, these lines over here, passive oxygenation, during pre-oxygenation, not a big problem. Bag mask ventilation, a big spike here, a smaller spike for intubation, and cough inflation, right? Again, now during extubation, not such a big spike, just small spikes, small waves during laryngoscopy, deflation, and extubation. But when the patient coughed into a Hudson mask, when the Hudson mask was put after extubation, the patient coughed, again, there's a significant amount of particle generation. And many of these are small particles. So it appears that, so one study told us that tracheal intubation did not result in significant particle generation, but this study showed it did, especially bag mask ventilation. And both studies seem to suggest that coughing seems to be a very important aerosol producing maneuver, and extubation to a lesser extent, right? So there is conflicting data, and maybe the risk is not as high as we thought, but the risk is definitely there. there is no question that aerosols are generated during the sequence of tracheal intubation. Patient cough is a consistent aerosol generator, and therefore it is prudent to continue to take all precautions during intubation for contact, droplet, and airborne transmission. Wear the appropriate PPE, follow standard recommendations. Please do not change practice because you've read that one study. Do not let your guard down. Okay, so I'd just like to end by saying that, we've always been there for our patients, but this is a time when we have to be there for ourselves, look after each other, look after health and safety, and we owe it to ourselves and our families. So please take care, stay safe, and thank you very much for inviting me and listening to me.
Thank you, Dr. Jayaprakash Mulail and Dr. Dvetia. Excellent talk. Jayaprakash was very lucid and very understanding with the basic, even people who cannot, who do not know anything about research methodology. As usual, Dvetia is, we know him very well and how they talk and all. Wonderful talk. He was the past editor and all. He has thoroughly read that. And I have two more chairpersons with me, Dr. Harsur, who was the earlier editor and who is and Dr. Bajwa, who is also editor of IJA. Both are doing a lot of work on research methodology. I think they can initiate discussion and furthermore give any doubts or clarifications or other things, add to this thing. Over to you, Dr. Harsur and Dr. Bajwa, please.
Harsur sir is there or not?
He's there. Harsur sir is there. Sorry, he's there.
Venkatagiri sir, Harsur
Yes.
sir is not, he is not there now. He left.
He's left. Okay. Bajwa, you can. Oh, Harsur is calling me.
Sir, unmute.
Harsur is there with the, sir, there is a question to Dr. Dvetia. His audio is not working. Patient coughing on surgical mask. What is the thing? That is what Harsur want to ask. Patient coughing on surgical mask.
I think Dvetia sir is also not there.
Sir, I think he is also left, I guess. He is also not in the board now.
Bajwa, you can contribute more for these things, both the things.
Yeah, I will just convey my things now.
Yeah.
Regarding the first talk, I was not able to log in at the right time. There was some difficulty. But regarding the research methodology, the last part I heard, it was absolutely very good. In the context of this COVID era for the last 10 months, the research methodology has taken a backseat. Previously, we used to do the ISA research methodology workshops almost every 2 to 3 months now. Now it's become almost impossible to get the physical workshops done. So we have to redesign our module to start the research methodology workshops again, so that on online research methodology workshop from ISA side can be done at the regular intervals. As many I've seen sites, they are offering courses in the research methodology, but the ISA module is a unique one with the interactive sessions also. So in the coming days, I think with the help of all the other people, we are going to design this module so that everybody who is interested in the research methodology can attend these online classes also. Regarding the various parts of the research methodology being conveyed, those are absolutely right. And what the guidance we have to give to the people here is that everybody has to show enthusiasm. You have to shed a lot of ego to learn the research methodology process. I may be a professor, I think I may be knowing too much of the research things, but in reality, the things are very different. When so many articles are coming for the publication in the Indian Journal of Anesthesia, the most flawed thing is the methodology. The methodology is so much flawed that in spite of multiple revisions, you cannot correct the methodology. Once you start a thing on the wrong foot, the entire, just like it's like buttoning the first button of a shirt in a wrong manner, all the buttons go wrong. So same goes for the research methodology also. If the research methodology follows a correct path, then the entire methodology will be good. So the need is there to at least make everybody aware. And I think this is the right time. Online platform will be more appropriate to cover the research methodology in a unique way. Regarding the Diwakar sir, he is presented very beautifully. One of the study was a deeper and deep anesthesia versus the lighter anesthesia, lighter pain of anesthesia on the outcome. Now, the reassurance is there that we have to give the deeper anesthesia, but in reality, what happens whenever we are facing the patients with the cardiac comorbidities, the neurological comorbidities, we always try to give a deeper plane so that the stress response, which is going to cause more harm than good, is more associated with the regional lighter anesthesia. Lighter pain of anesthesia on outcome. Now, ideally, I think it's an individual patient, always individualization. In reality, what happens whenever we are facing the patients with the cardiac comorbidities, the neurological comorbidities, we always try to give a deeper plane. The stress response, which is studies actually, we require a much larger comorbidity containing all the different comorbidities like cardiac, renal, hepatic, so that the deeper plane and the lighter plane anesthesia can be compared in a very efficient manner. Then coming about the studies about aerosol generation from the bag and mask procedure, the extubation, the intubation. Ideally, when the COVID came, we were more afraid to intubate the patient in ICUs, but extubation is always dangerous. That is very well known, because intubation we always take the high precautions. But during extubation in ICU, the patient is almost gets negative by that time the extubation is done. In the OTs, definitely. Now we are facing this problem where patients are coming for operations with the history of COVID. But what we are trying to give, we are preferring regional anesthesia more on the sides rather than giving the general anesthesia. But aerosol generation, how much risky it is, how much exposure is required, and there are so many studies coming with the droplet reticuli hanging in the air, if the coughing or bag mask ventilation, and many studies say they settle down, many studies say they keep this one hanging in the air for 2 to 3 hours. So also it's a conflicting data, really it's a conflicting data. But one thing was good, that still it may not be that much dangerous also. And regarding the first study, the neurodevelopment changes, the ideal thing is that we anesthesiologists have to start doing the follow-up studies, because in India, there are so many factors which are going to come in between these type of studies, such as intellectual level, the economic levels, the understanding of then the growing up of the different migration to different cities. All the pediatric patients, if you are going, giving the administering general anesthesia today or enrolling for the studies for the next 5 to 10 years, whenever you want to follow up, you have to make the people aware. When you are enrolling such patients, make them aware that we are going to have this, the results oriented, it's a result oriented anesthesia. But again, the intellectual level, the people may not, they are not compliant. So these studies, I think they are very good studies. They were taken in the Indian context. So the paper presentations, all the paper selection were by Dr. Diwakar sir was excellent. Now I think Diwakar sir is there. I hand over the baton to him. Diwakar sir, good morning.
Good morning, Dr. Bajwa. So I heard all your comments, and I think you're all very valid. The question that was asked is about the face mask during coughing. And of course, we all know that face masks will reduce the amount of transmission. But I think what the paper was showing is that coughing, in many of the Western countries, they advise N95 masks only for OT, for aerosol generating procedures, and ordinary face surgical masks for outside the OT, for non-aerosol generating procedures. So for them, this was important because it showed that coughing is also a very bad aerosol generating procedure. And maybe they need to wear N95 masks, even in OPDs when they're examining patients. And even for us, if you're not wearing N95 masks when you're examining patients or something in OPDs, then maybe you need to step up your level of protection, because coughing generates as much aerosols as, say, maybe even the traditional aerosol generating procedures. So I think that might be the message coming through.
10 ml direct 1 cc.
That was a question from the Harsoor sir about the surgical mask. I think, sir, very well taken, and that study was good actually. The extubation never highlighted in Indian context in the Indian Journal of Anesthesia. We are waiting for a study regarding the intubation and extubation, but comparing the COVID patients is itself a very difficult process to enroll these patients on your study protocols. Venkatagiri sir, your inputs?
Dr. Harsoor is there. Harsoor, we have unmuted him. Is Harsoor sir?
I don't think so. He's there.
He had that doubt because he had some problem with voice. He is there. His mic is not working. He has given a message. Anything
Sir
you
is
can
posted in a chat that his mic is not working.
Any question, Harsoor sir, you can put in the chat box, Harsoor sir. Shilpa, any questions in the chat box have come for this session?
I think he's trying to type now.
Yeah.
Just wait for a half minute. He's trying to type.
Okay. No, the others in the chat box that has come for this session.
Meanwhile, other people can also clear their doubts till the question comes from the Dr. Harsoor sir.
Yeah, that's what I was asking. Any other questions are there? You can put that.
Participants can unmute themselves and ask the question.
Sir? Sir? Bajwa?
Yeah, sir.
Harsoor, he has called that his mic is not working. He told Bajwa has sufficiently asked and given that questions. It's all right. Nothing more that. Any other comments from Dr. Harsoor or Dr. Mulail? Any other comments? If there are no comments,
these are our best people of our country who have already presented the best things in the best possible manner. I don't think so. Anything more is required in this short span of time. The discussions can go on, but I think almost everything is covered in this type in both the lectures.
Yeah.
Very well presented. The selection of studies was really good. The theme, excellent theme.
A very lucid talk by Dr. Mulail and Wonderful talk, and
I really missed that part, the first part, because the
Yes,
people
pretty
were not able to
understood.
log in.
Very simple, lucid, and the way which he has presented, we have not heard. We are hearing for the first time. Wonderful presentation. Then shall we close this session? If it is there.
Over to you, sir.
Okay. Thank you, Dr. Diveti and Dr. Mulai, and thank you, Dr. Harsur, Dr. Bajwa, and all of our participating in discussion, all the viewers and delegates for this session and attending. Thank you, everybody, and we will close this with thanks to the speakers and the chair. Thank you.
Thank you,
sir.
sir.
Thank you very much.
Thank you.
Thank you, sir. Bye.
Thank
Over to
you.
Shilpa.
Thank you, sir. Thank